Welcome everyone. This is Dr. Sharad Jaitly from New York on our website, your favorite website, MuniMeterHealth.com, which is dedicated in educating everyone about the human heart and its illnesses, as well as its treatment philosophies. So, without any further ado, as you know, we are on the two channels, the Facebook and the YouTube. Hopefully, you're subscribed to both. So this way, you can use one over the other, just in case if there's a malfunction of any of the apps. So thank you again for your enthusiastic support on watching MuniMeterHealth.com, your favorite website on cardiology. Without any further ado, let's delve into the subject matter. Today we're going to be discussing LV remodeling. What is LV remodeling? Now, very interestingly, remodeling is a connotation that we apply positively when we are applying it to our house. Like I remodeled my kitchen, or I remodeled my deck, or I'm remodeling my master bed suite, etc. It's all the bathrooms. So that is a positive connotation in real life. But in LV, in the cardiology world, LV remodeling is a negative connotation. Just remember that. It's an adverse effect, or the adverse mechanism by which the heart is tending to respond to various pathogenic processes, if you will. Now, commonly the remodeling is occurring whenever there is myocardial necrosis. So remember, if there is a necrosis that's occurring anywhere within the myocardium, which is again, the other word is acute myocardial infarction. If that is occurring, remodeling begins. The other causes, let's do the causes first, and then we'll get to the pathophysiology. Heart failure, for instance, any cause of heart failure, for instance, long-standing hypertension where there's a burnout LV cavity or LV failure that occurs. So LV has remodeled, we'll call it. Valvular heart diseases, if you will. Now, valvular, there are normally the mitral regurgitation we are talking about, and the aortic stenosis chiefly, and of course the aortic regurgitation also. So these are the three common causes of LV remodeling. Now remember, in mitral stenosis, the LV is not affected because LV is spared. That's the only chamber. They might ask you on the medical students board, by the way, which chamber escapes out when there is one valve lesion out of these four. It's the mitral stenosis where the left ventricle escapes out. It's a normal size, and so on the contrary, it's smaller left ventricle. So it does not have any effects, obviously, because the valve proximal to the LV, which is the mitral valve, is the one which is stenosed. So anyway, so coming back to the remodeling here, just to let you know, all forms of coronary artery disease, and chiefly the myocardial infarction, will do it. Heart failure will do it, and valvular conditions of the above three kinds will do it. What is remodeling? Now let's draw the heart, for instance, here. Here is your LV cavity. We're just looking at what you may call is the left ventricle. We are not looking at anything else. So when we draw the left ventricle, it appears somewhat like this. I'm drawing the left ventricle here. Not a great drawer, as you see, and obviously this is going like this. So when the hypertrophy occurs uniformly, if you will, on the septal, on the lateral, on the interior, and the inferior, etc., all walls. Now, if the hypertrophy occurs concentric, we call it a concentric variety. What is a concentric hypertrophy? When it is uniformly in all parts of the left ventricular wall. Now, take an example here. Now you have a left ventricle, and which may dilate in this fashion. I'm just drawing it schematically so you have an idea as to what's happening. And then there is thinning of the left ventricle on this side. So now you have an eccentric variety of left ventricular hypertrophy, and we'll define the condition in which it occurs. So this is the eccentric variety. So what have we learned so far? There are two types of LVH that are occurring as a result of certain conditions. Now, if you have a systolic overload, remember, if you have a systolic overload, like in example aortic stenosis, for instance, or maybe it be hypertension, those are the conditions where you have a systolic and you will have this kind of a concentric left ventricular hypertrophy. And if you have a diastolic overload, if you will, that diastolic overload will result into an eccentric variety of hypertrophy where there is thinning on one side and then hypertrophy on the other, and therefore the LV dilatation occurs. There's an LV dilatation also. Here the LV cavity is actually smollened. So the LV cavity is either the same size or it's smollened, but LV dilatation is a typical manifestation, or a sign of eccentric kind of left ventricular hypertrophy. So the diastolic variety typically occurs in a setting where either you have aortic regurgitation, you have a mitral regurgitation, and sometimes even in later stages of hypertension, I'll say, where the hypertension has failed sufficiently that the concentric hypertrophy can actually merge into more eccentric variety, and now the LV has really dilated and resulting into heart failure. So very, very late stages of hypertension, and obviously all forms of cardiomyopathic hearts, if you will, like the drug-induced, alcohol-induced, smokers cardiomyopathy, thyrotoxic cardiomyopathy, they'll all have LV dilatations, and as a result they'll have eccentric type of hypertrophy, LV remodeling. So what have we learned so far? There are two types of LVH, left ventricular hypertrophy. One is systolic, the other is eccentric. Concentric versus eccentric. One occurs in a systolic overload, which is concentric. One occurs in a diastolic overload, which is eccentric. The classic prototype examples are aortic stenosis and hypertension in the systolic variety. And in the diastolic variety, we have aortic regurgitation, mitral regurgitation, and hypertension. Okay, so the necrosis from an acute myocardial infarction that occurs, for instance, now if you have this portion of the heart that is not functioning, for instance, now this has suffered an AMI. So assuming that this was the normal looking left ventricle, what will happen is this will show signs of hypokinesis. So you may have first initially a hypokinesis. That means the segment will not contract inwards. Then you may have akinesis where it does not move at all. And then you have dyskinesis where actually it starts moving outside. So when the segment starts moving outside during systole, because remember during systole the ventricle has to move in. Now, so that's called normokinesis. But if it's not moving in or subnormally moving in, it's called hypokinesis. When it's not moving in, it's called akinesis, when it does not move at all. And dyskinesia implies when it actually starts moving outward, which is not a good sign. So in an acute myocardial infarction, initially one should see all these three phases until dyskinesia occurs. So a dyskinesia like within 24 hours, which is the norm after myocardial infarction, a dyskinetic segment implies that that segment is not contributing to the stroke volume. What is stroke volume? Let's quickly look at it. I've defined it in other video vignettes, if you will, but a quick equation for stroke volume is the following. Stroke volume is left ventricular end diastolic volume, which is at the end of diastole what the volume is, minus or subtract that with left ventricular end systolic volume. So say the left ventricular end diastolic volume is 150 minus, say it was 80 cc's here, left ventricular end systolic volume, that means after it has ejected. What is the stroke volume? It's about 70 cc's. So you have a means of knowing what the stroke volume is, and the stroke volume tends to suffer when you have dyskinesia. That segment is not functioning, and if it is not functioning, it's moving outwards, it's not contributing to the stroke volume effectively in the left ventricle. As a result, the heart will have to either function subnormally or it will have to work harder. So how does it work harder? By moving hyperkinesia on the other side. So the other segments will have hyperkinesia and therefore will start hypertrophying here, and this will be thinning out because of the myocardial necrosis. So the typical eccentric type of LV remodeling occurs in a setting of AMI also. So just remember that we will have hyperkinesia on the opposite side, the diametrically opposite side of the left ventricle, whichever way the cavity is being looked at, and the place where the actual acute myocardial infarction occurred, that's the place where you'll have the thinning. So the thinning and hypertrophy, they can go in concert with each other, contributing to this LV remodeling. But you might ask, why is the left ventricle contributing in that fashion? Well, that's the compensatory mechanism. Unfortunately, it also causes the mitral valve to, because the mitral valve, remember, is between the left atrium and left ventricle, and that starts malfunctioning as well. So there is increased mitral regurgitation as well. So the MR that can occur from an acute MI as a result of LV remodeling is a secondary MR, we call it, and that mitral regurgitation will only progress and get worse and worse and worse. Okay, just so that you know. So in a nutshell, what you've learned is LV remodeling. Now there are different agents specifically, and I commonly only quote two. One of them is the ACE inhibition. If you were to do an ACE inhibition with any drugs, captopril or what are the prototypes, all the prils that you will, ARBs will also have a very negative effect on LV remodeling, which means it's a positive effect for the patient. So ACE inhibition and ARBs, and then beta blockers. If you were to look specifically, the carvedilol has shown a great deal of benefit. So, and then you have a fourth group of drugs, which are aldosterone antagonists. So basically, you're looking at four groups of drugs: the ACE inhibition, the ARBs, the beta blockers, and the aldosterone antagonists. These four groups of drugs, they can nullify the remodeling, and therefore the patient will feel better. And they're commonly used soon after the heart attack. They're commonly used in valvular regurgitations. They're commonly used in all forms of heart failure, and of course in various valvular conditions like I talked about, and in hypertension and cardiomyopathies. So all these drugs are very, very helpful. They have positive effects both on morbidity and mortality, as well as in reversing the LV remodeling. Now here's another term called reverse remodeling. Reverse remodeling never occurs totally to become totally normal LV, but the fact is that at least the delay in remodeling has occurred, or sometimes you can put a stop to the remodeled hearts, in a quote unquote, where further remodeling is not occurring as a result of the medications that have been instituted. I suggest that use the beta blockers, ACE and ARBs, if the hemodynamics permit, right within the first day of the acute myocardial infarction to prevent this LV remodeling, which is a very, very important entity we are starting to recognize in the past decade or so in cardiology. Thank you again for watching MuniMeterHealth.com. That was the only subject we had within the scope of our video vignette length. So stay tuned for more stuff coming down the line. And I thank you again for your enthusiastic interest. Thanks again. So long. This is Dr. J.